This lecture is being brought to you in part by the generous gifts of these sponsors.
All right, are we on? We are on. All right, Ken, thanks for that wonderful introduction. Thanks so much for the chance to be part of the IHMC tradition. It's wonderful to be here with so many friends, dive buddies, fellow eye doctors. This is going to be a great night. And I think you're going to like this story. Wait for it to buzz. So, we all like the tradition here at IHMC about talking about wellness, longevity, and Dr. Adia has been a speaker here previously. Rob Patton sent me his book, Outlive, which is a great book. I recommend it. I just finished it a couple of weeks ago. And he talks about the 4 horsemen of death, the diseases that cause the deaths of most Americans: heart disease, cancer, neurodegenerative disease, and type 2 diabetes. But he forgot one, didn't he? What's the number one cause of death in Americans under the age of 44, which of course is most of us? It's injury. And don't believe me, this is from the National Academy of Sciences, Engineering, and Medicine. It's chilling to think that as many as 1 in 5 of these deaths are preventable. If the person had gotten better care, they'd still be alive. That's 20 to 30,000 deaths per year in our country. So this is the part, if you guys have heard military people speak before, this is the part where you say the DOD disavows anything I'm about to say. And in general, that's true, but in this particular topic, as of 13 March 2018, that DOD instruction was signed, which makes what we're about to talk about the law of the land in the Department of Defense. And you can feel good knowing that your relatives, if they ever go into battle, God forbid, they're going to be well taken care of. It's also used by NATO. We spent a lot of time training the Ukrainian military, the Israeli Defense Force, and interestingly, both Chinas. I love that. Taiwan and mainland China. They agree on at least one thing. I will disclose that I have a financial interest in this book, although Debbie, where's Debbie? Debbie can tell you that it's not as much of a financial interest as we would like. But, you know, it was never going to be a bestseller. This book is hopefully going to be about the impact. This is a great story, but we don't want to have to start over again somewhere in the future. My co-authors on this effort, and this has got a really cool little pointer, Kevin O'Connor. Does that name ring a bell to anybody? Right now he's the White House doc. But when he started working on this project, he was the command surgeon at Delta, if y'all know Delta. And just a tremendous person, a great partner, very, very smart guy. And the last author is our son, Jeff, who has been a SEAL, spent 7 years in the CIA, and is currently a fire chief in Springfield, Missouri. And he's had to sit through this TC3 training in every one of those organizations. Plus, he's a Georgetown graduate, so he's way better writer than either me or Kevin. So a lot of the quality of the book is due to Jeff. I will admit freely that it's a little weird to have an ophthalmologist talking about battlefield trauma care. It just is. But I'm not a trauma surgeon, I'm not a combat medic, I'm not an ER doc, but I was a Navy SEAL platoon commander for 4 years, and I did spend an amazing 5 years at the Navy Experimental Diving Unit. After I got out of the SEAL teams, Deb and I, God bless her, we packed up our daughter and our dog and went from Coronado, California to Augusta, Georgia. I don't recommend that, and God bless Deb for making that trip with me. But the time at the Experimental Diving Unit was really instructive. Does anybody recognize this little dive rig right here. That's not your basic Scuba Pro scuba tank. That is an oxygen rebreather. They cost about $10,000. They last a real long time, and they'll kill you if you dive them wrong. So I spent a lot of time working on that particular rig, which we're going to come back to on the next slide. So, excuse me for a drink of water. Dry mouth is my version of long COVID. So if that's all I have to worry about, then I count myself lucky. So I went to Bethesda. I did my ophthalmology residency with Dr. Steve Chalfin. He mentored me through those 3 years. I managed to get through them okay. We came back to Pensacola, and I was assigned at the Naval Hospital here with Steve. And shortly thereafter, the admiral who was in charge of the Navy SEAL community decided that he wanted to have his own medical research program. And he was nice enough to offer me the job to direct it. And he was nice enough to have the Bureau of Medicine send another ophthalmologist to Pensacola to backfill me while I was out doing SEAL things. So for 15 years, I ran this program and practiced eye surgery at the hospital. It just doesn't get much better than that. But we're going to talk a lot about battlefield trauma care, but this program was much broader. We had one of the early tactical athlete programs. I mean, the SEALs are tactical athletes, but back in the early 90s, they weren't really treated as such. So we fixed that, and they are now. They've got a good rehab program. They've got good human performance. They're treated as professional athletes now. Laser refractive surgery. About a third of the people in the country have vision that's bad enough to keep them out of the Navy SEALs. So they could have their vision fixed with refractive surgery, but then the SEAL program wouldn't let them in because it wasn't a great operation. And then in 1995, laser refractive surgery came along. It was a new operation. It was much better. We needed to take a look at it, and we did. We did the research and we did the politics to get laser refractive surgery approved for the SEALs and now for all of the Army special missions guys and naval aviators. So that was a great program. This program, you as taxpayers will enjoy hearing about because it saved you about 25 million tax dollars. This oxygen rig that we talked about, the SEALs weren't happy because the CO2 scrubber didn't work as well as they wanted it to. When you exhale, you have a lot of carbon dioxide in your breath, and it has to be taken out by this carbon dioxide scrubber, and that didn't last long enough. When I went back and looked at the report where they had tested it wrong. They'd used the wrong physiologic parameters to test the rig, so the admiral had them go back and retest it. It went 3 times as long as they had advertised before, and now 40 years later the SEALs are still swimming this rig today. So they didn't have to buy the new version of the oxygen rebreather that they were talking about. So that one project paid for all of the battlefield trauma care research that we're going to talk about. So that's a little background. 1992, I was the research program manager, but I knew that I knew nothing about battlefield trauma care. So I went out and got myself certified as a trauma instructor and went around the DoD teaching medics and doctors about battlefield trauma care. And in the process of doing that, I started to read some of the literature that pertains. So if you take a group of combat people who've been wounded and look at where the fatalities occur, these bar graphs, this is the battlefield, this is the first hospital, this is the second hospital, this is the third hospital. Where do all the people die? Before they ever get to any hospital. So all of a sudden, battlefield trauma care became way more important once that dawns on you. The next thing that hit me was I came across this paper by a Navy captain, J.S. Mon, And this was at the end of Vietnam. And he was at a hospital there, and he was a scientist, so he was looking at the people who came in and cataloging what they died of. And his paper said that of 2,600 people that died at the hospital, 193 of them had nothing other than a gunshot wound to the arm or the leg. So that's 193 deaths, but that's 2,600 fatalities. Our total number of fatalities in Vietnam was over 46,000. If that same percentage applied, that's over 3,400 Americans that died because nobody put a tourniquet on their arm or leg. In the same paper, he makes the remarkable statement that our ability to care for people on the battlefield has not improved since the Civil War. And the amazing thing is, by 1992, it hadn't gotten any better. This is a paper from the end of World War II by an Army doctor named Wolf. He said, hey, this tourniquet that you're giving us doesn't work. And it doesn't control bleeding no matter how tight you try to pull it. This is the tourniquet. What is it missing? This thing has no mechanical advantage. It's like trying to pull your belt tight enough to where it cuts off the bleeding. What you want is something that has mechanical advantage, either a windlass or a ratchet. This didn't have that. So in 1992, when I started working on this project, guess what tourniquet we were still issuing? We were issuing the one that was proven not to work in World War II. And the courses that we were teaching emphasized to the corpsmen and medics that they should not use the tourniquets that they had just been issued. And you're thinking, Whiskey Tango Foxtrot, right? Exactly right. And so at this point, I'm a little confused as the trauma instructor, but I'm hanging in there. I'm teaching what the protocol says, because the thought was if you put a tourniquet on the arm or the leg, that would cut off the blood flow, and they might have to have their arm or leg amputated. And then Debbie and I take the kids to Fripp Island, and Jeff and I go for a run. I tear my meniscus in my left knee, and what do? Go in to have it fixed in the OR. And so they start an IV, and the next thing that they do for me is to put on and I mean, I looked at it and I said, what in the world? And I tried to sit up and protest, and they immediately gave me some more sleepy medicine, and I settled down. But the next day, I went in to see the surgeon, and some of y'all may have met him, Jeff O'Brien, wonderful guy. And I went in and said, hey, Jeff, I'm a trauma instructor. We teach our corpsmen and medics not to use tourniquets on the battlefield because of damage to the tissue that could cause them to have their leg amputated. And he looks at me and he goes, Frank, what are you talking about? He said, we use these things every day in the operating room. Nobody has to have their leg cut off. We don't have any problems. And I thought, I don't understand. I really don't understand. So we need to go back and look at this issue. And then when you went back and looked at the evidence base for other things that we were doing in 1992, that was pretty spotty as well. The courses that we taught were civilian courses, so you take a civilian course like you'd use out in front of IHMC, and you try to translate that into the hills of Afghanistan. They're a little different, but the courses didn't reflect that, so that needed to be fixed. The fluid resuscitation. Do you guys all remember lactated ringers and normal saline? Oh yeah. That was what we did. If you were wounded and in shock, we would give you 2 liters of that. Was that a good thing or a bad thing? It was absolutely a bad thing. We killed more people than we saved by doing that. And the literature is clear on that point. Battlefield analgesia. I kid you not, we were using the same morphine injections in Afghanistan that we were using at Antietam and Bull Run. So, looked like that might be a good research project. So we got to work, and you know, as we started it, you ask yourself the question, How could we be so far behind in such a critical area? And the answer is, we're not as smart as we think we are. Advances are not inevitable. How is it that we put a person on the moon before we figured out it would be a good idea to put wheels on luggage? 1969, right? The moon landing. 1972, the patent for wheels on luggage. We're just not as smart as we think we are. And the book has a few other examples. This is kind of funny. The radical mastectomy story is not funny at all. And yet the same thing applies. We're not as smart as we think we are. If you are thinking of proposing a change to anything, there's an innovation risk, right? I mean, if you just keep your head down, do your job, stay quiet, you're going to do well in your organization. If you try to come in and make big changes, you guys all remember the Edsel and New Coke? It's a good way to get fired. And sometimes you can be absolutely right, like General Mitchell, one of the country's best aviators in World War I, came home and started telling all of the people in Washington, airplanes, airplanes, got to have airplanes. Army didn't want to hear that. The Navy didn't want to hear that. They wanted battleships. So it turns out in World War II, General Mitchell was proved 100% correct. What happened to him? He got court-martialed and died young. So you can be 100% right, and yet if you put yourself out there as an innovator, it can backfire on you. And then evidence in medicine. Everybody's heard of randomized controlled studies, right? There's no randomized controlled studies on the battlefield. It's not doable. And so you have to learn and accept that you're going to make the best decision that you can with the best evidence that you can come up with. You can't sit around waiting for a study that's never going to happen. So we went to work. We got a lot of help. This is the Uniformed Services University up in Bethesda. Beautiful facility, smart people, military-oriented, and they helped with this. We had a lot of people from special operations involved. And our goal was to prevent every single preventable death that we could. That's the real metric, right? We don't want anybody to die that didn't have to die. We did look at the evidence, but we required that the things that we did in 1992 be defended by evidence too. We can't just say, okay, we're going to give 2 liters of normal saline because that's what we do. No, what's the evidence behind doing that? And it wasn't good. We thought about the combat mission. You can't stop and do some medical things when you're in the middle of a gunfight. And importantly, one of the things you learn in the SEAL teams is you don't plan any kind of a mission without getting the senior enlisted guys there. And so we had rooms full of SEAL corpsmen, Marine Corps corpsmen, Army medics, and they were part of the project, and they were a big part of it. So it took from 1992 to 1996. It was published as a special supplement in military medicine, and it was as evidence-based as we could make it, and it was customized for the battlefield. And this is what that paper said about tourniquets. It's important to stop major bleeding as quickly as possible. You're not going to damage the limb if you only leave the tourniquet in place for an hour, as every orthopedic surgeon in the country will tell you. And yet, the military is telling people not to use them. And we made a strong case for everybody in special operations carrying a tourniquet all the time, on themselves, readily available. You don't have 5 minutes to look in your pack if you've got a big bleeder in your leg, as you'll see when we look at. I have to warn you that we are going to see some wound pictures. Anybody that gets upset at that, I don't think they'll be too bad, but you will see a couple of wound pictures. So, 1996, what was going on in the country? That was pretty quiet. There was no war going on. So what we did with that paper was go around and present it at conferences, present it to military leaders, just try to introduce the concepts. And there was a lot of talk and a lot less action. So when 9/11 happened, the only people that were really using TC3 were the Navy SEALs, the 75th Ranger Regiment, God bless those guys, I love them, the Army Special Missions Unit, Delta. There's a story in the book about my presentation at Delta. It was unique. And the Air Force Pararescue guys. So most special operators and all of the conventional units were not using TC3. So 9/11 happens, and most of the military went to war in Afghanistan and Iraq without tourniquets, with predictable results. And that picture, sad to say, is an autopsy picture. This is a Special Forces sergeant, one of the country's best soldiers, who bled to death from a gunshot wound to the lower leg. He didn't have a tourniquet. His unit members tried to tear up their t-shirts and make a tourniquet. Didn't work. This guy bled to death. And we had commissioned a study. This guy here is John Holcomb, who is one of my heroes. He was the person that, at the time, I was the command surgeon at the Special Operations Command, and I asked him to do this study and tell us how our Special Operations troops who had died, how they had died. There were 82 deaths at that point in time, and a number of them could have been saved with things as simple as a tourniquet. This is a tragedy. General Nyland, it wasn't isolated to special ops. This was a Marine in 2005 in Iraq, shot in the leg, femoral bleeding, which looks like that. You've got about 4 or 5 minutes before people start to die with that kind of bleeding. And the corpsman arrives 10 minutes later. You can see why everybody needs to have their own tourniquet. He tried to use a hemostatic agent, which is like a bandage that has clotting substance in there. That didn't work. They tried to start an IV. That didn't work. They finally tried to apply a makeshift tourniquet. That didn't work. And so this Marine dies. You know, this guy has mother, father, wife, kids, and he died. No reason for it. That happened 119 times, at least, between 2001 and 2010. You guys may know Admiral Bill McRaven of Bin Laden fame. This is a talk that he gave at the Texas Medical Association in 2017. He said, "It seems unthinkable that our best operators were bleeding to death over and over again," but they were. It's tough to change cultures. So far this is a bad news story, right? It's going to get better. So I took Dr. Holcomb's study, and the people in charge of special operations at the time were a 4-star Army general named Doug Brown and a 3-star Navy guy named Eric Olson. I took all those pictures up and said, "General, Admiral, these are our guys, and they died, and they shouldn't have. We can fix it. We need the funding and the authorization to go out and start training all of our special ops guys in these new techniques." They gave us $7 million, and we gave them back a bunch of live special operations troops. So we began to make the transition in 2004. It worked so well that by 2005, Admiral Olson signed a message that said, "Hey, this is not a volunteer thing anymore. Everybody is going to make this change." And we did. So that's 2005. After those events, pretty much everybody in the military started to do it. Word of mouth, reports in the literature. And the change happened, but it wasn't fast and it wasn't easy. Also in 2001, we put together a group of people to sort of have ownership and guidance of this project as the years went on. If you know medical guidelines, whatever medical guideline you make today, no matter how good it is, in 5 years it's going to be wrong, or could be wrong. So we got a bunch of trauma surgeons and emergency medicine docs and medics and corpsmen, and put them all in the same room 4 times a year and let them duke it out with every good idea that came along. Our charter was to maintain an active search for good ideas wherever they can be found. And we literally got good ideas from all over, and then talk about them, process them as though lives depended on it, because in fact they do. The ideas came from published papers. The medics would tell us what worked and didn't work when they were at the meetings. Every week, every Thursday since 2005, there's been a worldwide trauma conference. Debbie's heard me duck out of whatever was going on a million times to go and listen to that conference. There's 200 or 300 people on the conference, and we talk about every wounded American from the previous week. And we learn a lot from those types of things. So other locations as well, good ideas wherever they came from. So that's how I got started. Now, fast forward 20 years from 2004 to now. And when I say fast forward, think of hundreds of medical conferences, hundreds of meetings with leaders, hundreds of research publications, but we'll skip all those. What do we do in tactical combat casualty care now? Well, first of all, we teach them to treat their casualties as they would if they were in an actual gunfight. Tourniquets, of course. Combat gauze. This is, again, a bandage that has clotting substance in there. Put it on the bleeding place and it stops. Airway. Who here has heard of intubation? Right. Every medical show you ever see, they intubate the guy. That's what we were teaching our medics to do 20 years ago. There was no evidence that our medics could do that or that they needed to. So we don't do that anymore. You know, if you're shot in the face, if you're still conscious, the thing for you to do is to sit up, lean forward, and spit it all out. Clear your airway with gravity and the cough reflex. It works unbelievably well. I've heard of dozens of casualties over the last 20 years that have been saved by doing that. If somebody's in shock, no salt water, whole blood. Whole blood. You lose blood, you need blood. And so on. Tranexamic acid, think of it as a liquid tourniquet. The trauma surgeons would scream at me for saying that, but it can help you stop bleeding internally. And the medics can't get to your liver and your spleen, but this can help the bleeding there slow down. We have much better medications for pain, happy to say. So the items that are in blue are new since 1992. What do you notice about blue? Every single item is in blue. This is completely different than you would have been treated in 1992, and your brothers and sisters in the service would have been treated. Everything about it is new and different. And I have to take a minute and say thanks to all the guys that every change that we made, what we would do was pin the rose on somebody and say, okay, you believe strongly in tranexamic acid, please make the case to these other 50 disbelieving people. And this group of 19 medics and trauma surgeons and ER docs, they did it. God bless them. That's how those changes actually happened. Each of those was an act of individual leadership and courage on somebody's part. So, it sounds good. And you're thinking, yeah, but how do we know it's working? That's a great question. So 27 March 2002, I'm up in DC and I'm staying with a family friend. It was a woman, but it was a woman that Debbie knows, so it was okay. I'm sound asleep, 2:30 in the morning, phone rings. This guy, Kevin O'Connor, he says, hey Frank, were you sleeping? Yeah, Kevin, I was sleeping. He said, we just got home from Afghanistan. Now, he's with Delta at the time. This is them on the deployment. You know those TC3 things that we taught our guys? Well, we used them in Afghanistan, and you know what? They work and they save lives. I'm calling you at 2:30 in the morning because I want you always to remember this phone call. And guess what? It worked. Great story in the book. This goes back, yeah. So this is him in his day job now. Much less exciting. Yes. So this was the first ever published paper that said, hey, this medical heresy, this TC3 that people have been talking about, we just took our task force and went from Kuwait to Baghdad. We had 32 casualties. Nobody died. This plan is outstanding. And that was published in the Army Medical Department Journal. So the Army felt good about it because it came from one of their guys. To return to tourniquets for a second, and again, this is a painful thing to look at, but this guy is alive today, I think. He would not have been without these 2 tourniquets. So the tourniquet issue was still raging. A lot of people didn't believe it. A lot of doctors would yell at the medics when they came in and saw that tourniquets were on the legs. So this guy, John Craig, Army Colonel, grouchy old guy. He shows up in Baghdad. There's a hospital there called Ibn Sina. And God bless John, he went down to the ER with every patient that came in and recorded who had a tourniquet and how they did. Did it save their life? Did this guy come in and bleed to death because he didn't get a tourniquet? He recorded the outcomes and published in the Journal of Trauma that there were 31 lives saved in 6 months at that one hospital. Now think about the scope of the war. That's 1 6-month period in one hospital in one theater. The Army Surgeon General said, hey, Colonel Craig, what is your estimation of the number of lives saved in Afghanistan and Iraq throughout all the years of the war? And the answer he gave them was 2,000. 2,000 lives. So, and he also documented that nobody lost their arm or leg, just like Jeff O'Brien said. So this was really a turning point for tourniquets. And anybody that wasn't using tourniquets after this paper came out wasn't paying attention. One of the real landmark papers in the war was this one from Colonel Brian Eastridge, now Chief of Trauma at a big hospital in San Antonio. He looked at 4,596 deaths by going through the Armed Forces Medical Examiner files. You guys know when they bring the bodies up to Dover, they do autopsies and determine how they died. Well, so what Brian did was to say, okay, let's define who could have been saved and who could not have been saved. He found that, first of all, again, we talked about most of the deaths occur pre-hospital. 87% occurred before they ever got to a hospital. So it doesn't matter how good your surgeon is if the patient's dead when he shows up to the hospital. 24%, 959 of our American brothers and sisters died when they could have been, their death could have been prevented. That's just totally unacceptable. In contrast, this guy is a fellow named Russ Coatwall. He was the Ranger Regimental Surgeon. Fascinating little guy. He worked his way through college as a bouncer. He wasn't big, but he was massively strong. He is the most decorated medical officer from Afghanistan and Iraq. This guy would go out and get in a gunfight every time the Rangers went out and operated. He was right there. So he documented that since the Rangers had started with TC3 a long time ago, whereas most of the military had 24% preventable deaths, the Rangers had 0. This was the definitive paper. Okay, so let's talk a little bit about, you think the military makes these advances in trauma care during the war. Surely they're going to get to the civilian sector, and they're going to be used to save lives at home, right? We'll see. So I mentioned that by 2008, everybody in the U.S. military had a tourniquet, was trained to use it. The tourniquet battle was over in the military. There's a lady called Tress Goodwin up at the Uniformed Services University, and she published this amazing paper. She went through and looked at the EMS database. This is where the people in the ambulances record what happened, what they did, what the injuries were, what the treatments were. They looked at almost 9 million activations in 2008 and 2009. The total number of tourniquet uses reported, 0. That's a lot of people who died who didn't have to because they didn't get tourniquets. It's a stunning number. And it was the residual effect of the anti-tourniquet doctrine that was around everywhere in medicine. It wasn't just the military. It was everywhere. In every country, people backed away from tourniquets. It was a medical urban myth. And it's been responsible for thousands and thousands of deaths. So, in thinking about what to do about that, so we won the battle in the military. Yeah, we care a lot about the people at home. So a lot of the people that we work with started to think about how do we make these changes translate into the civilian sector when it's not happening. And 3 of the guys who did the best job of that, this is John Holcomb again. This is Lynn Jacobs, a prominent trauma surgeon up in Connecticut, and Don Jenkins, who is one of our guys and went on to be the chair of trauma at Mayo Clinic up in Minnesota. They came home from the war, and in their own little systems, they said, use these tourniquets, go out and use them. We know they work. And so they started to make inroads, but nothing really happened nationwide until the Hartford Consensus. So 2012, do you guys remember the details of the Sandy Hook shooting? It was horrific. It's the most horrific shooting we've ever had. And the governor of Connecticut asked Lynn Jacobs, who I mentioned before, what can we do to prevent fatalities in the next mass shooting? And Lynn called a group of people together. This is Norm McSwain, who was a national leader in trauma over at Charity in New Orleans. These 2 guys were the head medical officers in the FBI. This guy was a trauma surgeon from Dallas, and a SWAT lieutenant. Currently, he's the chief medical officer for Border Patrol. So you can imagine that this is a busy dude. And this is Karen Burns. She worked with Dr. Jacobs. She was a PhD research assistant. So it was basically a brain trust. How can we fix this? And Dr. Jacobs is one of those people who he's very soft-spoken but has incredible charisma and brings people together. He managed to convince the American College of Surgeons that what they've been teaching for the past 40 years was totally wrong. He managed to convince the White House. It was a little easier because Kevin was already at the White House, so that helped. But the next meeting brought together the White House, the American College of Surgeons, the DOD, the chiefs of police. It was a major force for good, and they published this document that came out as a publication of the American College of Surgeons. And what they recommended was stop the bleed. Has anybody heard that phrase around? It's everywhere now. It's everywhere. Stop the bleed. This is how it started. Dr. Jacobs got the American College of Surgeons and the White House to get behind it, and it's now a huge international success. This was the rollout for the program up at the White House in 2015, and there's Kevin. He got to speak, and the guy's a riot to listen to. But it's an example of what it takes. I mean, tourniquets to the military had seemed intuitive after 2008, and yet it's 2015, and we're just now making it happen for big America. So where have we gone since then? This paper came out just a couple of years ago. In 2019, one of Holcomb's residents, or fellows, I guess, Zane Hashmi, looked back at the same EMS database and said, okay, now out of 4.5 million activations, we have 7,000 tourniquets applied. And that's the good news. The bad news is they reckon that another 141,000 should have been applied. So how many of those people lived and how many died? We don't know, but a lot of them died. You know, so numbers are just numbers. You don't really relate to these things until it's your Marine or your SEAL who gets killed. We were at an event at Robin Rena's Patton's house when I heard about this. These things become real when it happens in your hometown. This is a 15-year-old young woman from Alabama named Lulu Gribben. She was at a beach in Fort Walton, got attacked by a shark, got part of her arm and part of her leg bitten off, would have died, but she didn't. Why not? She was saved by tourniquets. So you think, you know, all this work, all this international effort, but it doesn't become real until one of your neighbors gets saved. Another great story is a person who's often here in this audience is a guy named Kent Boland. I know a lot of you know Kent. So Kent had heard a lot of these discussions, and he's now the manager at the Floribama. Free beer, right? So he got Stop the Bleed kits at the Floribama. And just about the same time as we heard about Lulu Gribben at the Pattons, Kent called and said, we just saved a life with a tourniquet outside the Floribama. So you can't tell when you're going to need one of those things. Debbie and I have one of those Stop the Bleed kits in our car right now. I've not had to use the tourniquet yet, but I've had to use the combat gauze on an elderly lady who took a bad fall on a marble floor and split her head open. So, a few closing thoughts. I know you're ready for that. The TC3 has been a great success, but success can be perishable, especially in the military. We have a great way of uninventing things that we've invented. The book has a story about how we invented, or we realized that whole blood was the best thing to use for shock in World War I, and then forgot it, and then had to reinvent it in World War II, and then we forgot it, and we had to reinvent it in Afghanistan and Iraq. It's not funny. It's a problem. So, what I would ask of y'all is to be an advocate at whatever level that you can. Kent Boland just taking Stop the Bleed kits out to the Floribama. Get a copy of the book and send it to your congressman. Send it to your admiral or general. This is a battle that's not ever going to be over. I think we're going to continue to have to fight it. If you do anything that puts you in likelihood of being injured, and for me it's being out on my bicycle. I always have a tourniquet when I go out on my bike. If anybody here knows anybody at the Wall Street Journal, I'm working real hard to get this in the bookshelf section of the Wall Street Journal. We have to publicize this story if we're going to make it last. All right, and the last slide, this is a young SEAL student enjoying a day at the Mudflats. Happy to tackle any questions. Yes, sir. Oh, yeah. Sorry, Michelle. My fault.
All right, you mentioned that you have to wait at least, or you don't want to go over an hour, but if in a case for a tourniquet to be applied, what is truly the length of time that it needs to come off?
That's a great question, and we're finding that out in the Ukrainian conflict. I went to Poland to meet with the Ukrainians this time last year. In Ukraine, because they have no air superiority, there are no helicopters to come evacuate their casualties. So it is taking an average of 8 to 9 hours to get their casualties back to a hospital. That's too long, and they are losing arms and legs. So an hour is definitely okay. 2 hours is pretty okay. When you get beyond 2 hours, you enter a gray zone until you get to 6 hours. After 6 hours, TC3 recommendation is to wait until the person is at a hospital. Because when you take that tourniquet off, they're going to get a bunch of bad elements from the blood come up to their heart, damage their kidney. Bad things can happen. So, great question. Up to 2 hours is very safe. Sir.
Back in the mid-'80s, I did the 4Cs, Combat Casualty Care course in San Antonio.
Right.
Had a little different emphasis. We did talk about tourniquets, didn't stress them a lot. Excuse me, still use Ringer's lactate. Has that been replaced by the TCCC?
Mm-hmm.
Good.
The course you're talking about is Combat Casualty Care. Yeah. That has been totally replaced by TCCC at this point. And I'll talk a second about whole blood. If you are anywhere in the U.S. military right now and in a conflict and you go into shock because you've lost blood, you will get a blood transfusion. We use universal donor blood. So everybody's worried about getting the wrong type of blood in the wrong patient. So we take universal donor blood and we can give it to everybody. And we do. What percent of United States EMS systems do the same thing? Less than 5, yes. Less than 5%. It's not zero, but it's not many. And why? Just because it takes a while for people to get the word. It's more expensive than giving people lactated ringers. Lactated ringers is like sports drink. You know, sports drink is great if you're dehydrated. It's not great if you're bleeding to death. And it's not in doubt. There's paper after paper after paper that show if you lose blood, you need to have blood transfusion, not IV sports drink. But it just hasn't happened all over the country. And a lot of things that we do in the military have not happened all over the country. So if you have a chance, if you know a doctor that's in charge of an EMS system or has influence, spread the word. We are still spreading the word to Main Street America. Yes, ma'am.
So education is power.
Yes,
and I
ma'am.
appreciate that. As far as the tourniquets, I think you said within 10 minutes that they
It
needed.
depends on where you're bleeding.
Okay.
You know,
A limb.
if you're bleeding from your radial artery, you probably got 15 minutes.
Okay. So on the civilian side, do our police and EMT, the lifeguards, the Lulu Gribben type, do they have those on hand?
I would say that right now, as we sit here, about 60% of EMS systems have tourniquets. Probably more than that in police departments and fire departments have tourniquets. The Stop the Bleed program that Dr. Jacobs helped to mobilize has been spectacular.
So it's funded hopefully somewhere?
It's not funded. It is basically, you said education is power. The American College of Surgeons agrees with you, and so they fund it. They fund the educational outreach, but they don't buy the Stop the Bleed kits.
Okay, and where can those be purchased? What are the resources for the civilians? You said you have one in your car.
Oh yeah.
Okay.
You can buy
Here I
them.
am,
You
Susie
can.
Q,
They're
you
like
know?
they're like $30. You can buy them from Amazon, or I would recommend going to the American College of Surgeons site. If you Google "Stop the Bleed," you'll get 1 million hits.
Okay.
But go to the American College of Surgeons site, and you'll be sure to get the best tourniquet and the best hemostatic dressing.
Okay. Well, living along the beach areas,
Yes,
which
ma'am.
we are,
Yeah.
I mean, that's something I would like to know. I
Yes,
mean, you
ma'am.
have the Lulu situation, and I'd like to know if our lifeguards do have it, and if so, maybe the communities need to get those to them.
Yep.
Okay. Thank you so much.
Yes, ma'am. Sir,
Oh, I was just saying, Pensacola Beach lifeguards do tourniquets.
are you a Pensacola Beach lifeguard? Yay. When did you get the tourniquets?
I believe it was in the past couple years.
Okay.
Yes, I want to say in the past years. I just, pretty sure the past couple years. Sorry, but yeah.
So in the last the lifeguards have been very active in promoting tourniquet use, although there's some famous stories about surfers getting bit by sharks, and their surfing buddies will take these leashes that are on the surfboards and make a tourniquet out of those things, and they work pretty well. And the medics, EMS will show up and start to take the makeshift tourniquet off of the injured surfer, and the other surfers say, "Back off." That's happened multiple times. There was one up in North Carolina that got reported all over the place. But for a long time, the EMS guys were behind the lifeguards. Well done. Yes, ma'am.
I'm just curious when you're going to come back and talk about your diving experiences and your research.
Anytime.
Please. I'm sure you have adventures and all kinds of info. I would like to come back and do that, would you?
Ken, did you make a note, Ken?
Dr. Butler, thank you for your contributions to the medical community and to our country, to our DoD. You highlighted this on the very first question, but I'd like to dive into it a little bit more. From the 90s on, air superiority was a blessing that we had for the U.S. In a near-peer conflict, we will likely not have that, especially in the Pacific Island chain. Beyond the duration of the tourniquets, what other items of concern does the TCCC committee have regarding lessons learned from the Ukraine?
That's a long answer. If you get my email address, I just wrote about a 10-page paper on that. But think of yourself on a destroyer out in the middle of the Pacific, and you get hit by a Chinese anti-ship missile. Where is the next closest ship? 100 miles away, maybe? And so they've got to figure out, well, gee, what just happened? How many casualties? Should we launch our helicopter? It's a slow, painful process to make those casualty transfers at sea. And we're making the case to the Navy that you guys have to figure this out. Either we have to have another plan for replacing these tourniquets. As we talked about, you're good with a tourniquet for 2 hours, but if that helicopter's not there to pick you up and take you back to the ship where you'll be treated, you're probably going to lose a leg. And that's still better than being dead, but it's not what we're looking for. So sea battles in Indo-PACOM are a whole nother topic. They will be different from Ukraine, but they'll have a lot of overlap. Sir.
Thank you for a great lecture. Welcome to Pensacola. The Israelis are famous for trauma treatment. Are they embracing TCCC?
They're using our stuff. Yeah, we've invited the Israelis to all of our meetings for the past 15 years. The Israeli Surgeon General is one of my swim buddies. They are all over this, and they've used it. There's just a paper that I looked at before we came over talking about the differences between the first war in Gaza in 2013 and the current war in Gaza. They have embraced all of the things that we're talking about and are having tremendous success with them.
On that note, let's thank our speaker.
Thank you.